I know Pulm's on Friday. We're gonna finish up Endo today, and my goal is to get through all of the check-on learnings and everything, so you have all that to study for the exam. And then next week we'll have a review and a lab. So new material. So we're gonna wrap up 5 with the cases and check-on learning, and then get through 6. Okay. So 5 was all about cortisol, aldosterone, and a little bit about androgen excess. Okay. So you have a patient with signs and symptoms. No, wrong thing. Sorry, I forgot. Let's see, because we didn't finish the cases, the clinical cases, right? So that's this guy. Here we go. All right. Okay. And I'll post these today, but I posted all the other ones from lessons 1 through 4 on the lab section in Canvas, okay? So we have Brad Pitzel. He's a 28-year-old male, presents with easy bruising for the past 6 months. Rita? Remember last week? Okay, let's get more information. He was administratively separated from the military for failure to meet height and weight standards. He's gained 60 pounds in the last 2 to 3 years without a significant change in dietary intake, and he has a lot of abdominal weight gain. Review his systems, all you get out of him is he's fatigued. Now what are you thinking? What do you think can potentially be the problem? Cortisol, right? Is it high or low with this scenario? High, yeah. All right, what do you think of those vitals?
Elevated blood pressure.
Yeah, elevated blood pressure for sure.
Pulse
and his BMI is 43, so that's class 3 obesity. So kind of like solidifies what he's talking about, but now we add hypertension to, potentially hypertension to this scenario. Central obesity, and you do a good physical exam, you see a moon face, facial plethora, what's that? The redness, right? Yeah, buffalo hump, the dorsal cervical fat pads, supraclavicular fat pads. Man, this guy is everything. Large purple striae on his abdomen, thighs, and axillary folds. And then we have lots of bruising. Proximal muscle weakness is noted, and he has thin extremities. Now what are we thinking? We did a history. Are we still think cortisol is the issue? Yeah, Cushing's, right? So what do we do if I have a patient who, what I'm concerned for Cushing's? What do we do next after a good physical exam and history? Labs, yeah, okay. Well, we had labs because he was coming to see us, and they said there's slightly low potassium, but otherwise normal. And that was from a CMP, CBC, and a lipid panel. Is that enough to diagnose Cushing's? No. So what do we need? Dexamethasone suppression test. We need, that's one of them. There's 3 options for excess cortisol. 24-hour urine cortisol, and then that was a salivary test, right? And that's because when cortisol is high, it's hard to pinpoint. We can't just do a morning cortisol, right? Because it's the feedback loop is busted. Oh, this is just all the things that pointed you guys to Cushing's. And then more labs. You guys told me what they were. All right, so overnight dexamethasone is 7. So it's elevated, and his 24-hour urine cortisol is also elevated. Can we call it Cushing syndrome or Cushing disease yet? No, we can just call it hypercortisolism. So that's what I'm going to take from this case. This confirms that he has high cortisol in his blood, right? But what lab or test do we need to do to tell us where the problem is? Right? Because in Cushing disease and Cushing syndrome, they present the same way. Their initial labs also confirm high cortisol. There's one specific lab we can do now to help me. Is it a pituitary problem, ectopic, or adrenal problem? ACTH. ACTH points to the problem, okay? For insufficiency and in hyperfunction. It's coming back to you. Screening cortisol test consistent with Cushing syndrome or Cushing disease. We also were talking about obesity, hypertension, baseline ACTH, right? It's going to tell me, it'll help me make that diagnosis. Just all that's in the slides for if you use these to study. Okay, so plasma ACTH levels in hypercortisolism. Which one is considered dependent versus independent? ACTH dependent versus ACTH independent? Which one is independent? Adrenal or pituitary? Adrenal, right? Because it's excess independent of the pituitary's negative feedback, right? The adenoma or hyperplasia is working outside the normal feedback loop, making pituitary and ectopic dependent. Which one's most common? Ectopic tumor cancer, lung cancer, or an adenoma? Yeah. Okay. And this, I'm not going to read this, but this just breaks it down. If for whatever reason you're like, crap, I do not remember any of this, here you go. All right, so we get the ACTH back, and it is low. Okay, what do we think? Is this ectopic, pituitary, or adrenal if the ACTH is low? What is the problem? I hear pituitary. It's either pituitary cancer or adrenals, right? Okay, so what? So we're stuck, right? I don't hear anyone jumping and saying, I got it. Okay, so I'm stuck. So this is great. I'm on a test and I'm stuck. ACTH is low or high. This patient has hypercortisol, right? What should happen normally when their cortisol is high? ACTH should go up, down. So is the pituitary doing what it's supposed to do?
Yes.
In this setting? Yes. So is it a pituitary problem?
No.
Or ectopic? No. It's going to be the adrenals, right? Pituitary is working. So that's what you do on a test when you're like, shit, I forgot everything. No, go back to what normal is, okay? So, so we have Cushing's syndrome with low ACTH, and we need to do a CT scan, right? To rule out is it an adenoma or bilateral hyperplasia, okay? The explanation there will help you with studying. So now what do we do? Already told you. CT, all day. And we have an adenoma, so we'll refer them to surgery, but we need to address that hypertension and talk to them about obesity, even though potentially when we fix this, maybe that central obesity will improve. Questions on that one? Oh, yes.
Would we ever, if it was a adenoma on the pituitary, would we ever order a CT just for the speed of it, or I know MRI is like a study of choice.
Yeah, so you order an MRI, but you would do go to a CT if the MRI was normal. And just because the CT comes with blood, you just order the CT costs and then radiation, right? But in real life, sometimes you do the MRI and it's normal. And so, do people order both? Yes, but for learning, we're just going to do what makes sense and be the MRI pituitary CT for that.
Right.
Makes sense. Good question. All right, Serena Zen is a 20-year-old female. She's coming in for weakness, fatigue, poor appetite, weight loss, diarrhea, amenorrhea, lightheadedness, with standing for 7 months. No medical problems otherwise. She doesn't take meds. She's not a smoker or a drinker. Does this patient present like the last one? No, not at all. All right, any initial thoughts? Which hormone's off? Let's see. There's all the things. Is this presenting like excess hypercortisol? No. No. Okay, so let's do a physical exam. So orthostatics are positive. When do we check for orthostatic blood pressure? I know that was a neuro question, right? When do we check it? Yeah, hypotensive, dizziness, dehydration. That's when we can do this, right? And for her, what do you think made them do that? Maybe that lightheadedness was standing, and her initial blood pressure was low. Okay, so she's not sick, well developed, well nourished. Skin, increased skin pigmentation noted. Generalized pattern with darker pigmentation on her joints, her PIP, DIPs, and palmar creases. There's lack of axillary hair is noted. And here's her initial labs. What do we think is the problem now? Yeah. So which is a adrenal insufficiency, but can we call this Addison's yet? No, but it's more like Addison's in secondary, right? Because of what? Physical exam, hyperpigmentation, right? Okay. All right, we get those initial labs. Sodium's a little low, potassium's a little high, mild neutropenia. She's not pregnant. So again, you're still thinking as primary adrenal insufficiency or secondary adrenal insufficiency. Primary is Addison's, right? Problems in adrenals. Still thinking more Addison's. Does this make you yeah, this is expected in primary, right? You might have a little abnormal electrolytes. Okay. How do we, so from their physical exam and their history, I'm thinking cortisol insufficiency. How do I verify that? What do I do? An endo. More labs. Which ones? Cortisol is low. What should I check? ACTH, and what else? Cortisol is low, so let's just check what's low. Let's check the morning cortisol. Why do I do cortisol and ACTH in the morning? Yes, diurnal, right? Diurnal. So again, we're going to do it in the morning, and it's low. Because we have a better range for morning cortisols than when they're low versus when they're excess, right? Because when it's hypercortisolism, it's an excess and it's all the time. It's outside the feedback loop. But we can use cortisol when it's insufficiency, okay? So where's the problem? Adrenal or pituitary? Okay, so for sure we have low cortisol. Plasma ACTH is high. So is the pituitary doing what it's supposed to do when cortisol is low?
Yes.
Yes. Yes. Awesome. So the problem is in the adrenals, right? Okay. Now what do we do? Or should we get our labs? Should we do more labs, imaging? What do you want to do? Yeah, we can do imaging. We can also consider, we wouldn't do this test ourselves, but the cosinotropin ACTH stimulation test, right? We're giving someone synthetic ACTH, and we're going to see how the body reacts. But that would be done by endo, so I would do a CT. So ACTH high, cortisol is low, primary adrenal insufficiency. What causes Addison's or primary adrenal insufficiency? What's the underlying pathology or pathophysiology? Is it an infection? Autoimmunity, right? Destruction of, yeah, 90% of destruction you start to see symptoms. So this is an autoimmune condition, right? What is this person with Addison's more likely to get? Other autoimmune disorders, right? Okay. So then you get the name primary, right? Because primary tells me the problem is in the adrenals. Okay. So again, next step while waiting for endo, I'm going to do a scan. How do we treat this? Yeah, give them what they're missing, which is cortisol. What are things we need to know about cortisol? Do I just say, here you go, have a nice day, I'll see you in 6 months? No, what do we need to do? Yeah, sick day dosing, right? What is if I have a cold or I get pneumonia, what's my, and you give me oral prednisone, what do I do when I'm sick? Increase it. What if I have surgery or, I don't know, I'm, some traumatic thing. I'm in a boating accident. What? Yeah, I'm in a skiing accident, so significant trauma, then what do I do? Do I just increase that dose or do I do something different? We need more, it's trauma, so you would do the IV. These guys get that bracelet, right? Give me meds or watch me die. And managed by endo. Questions on this? Okay, all right. Well, you have a 20-year-old patient, so it's still Serena. You've successfully diagnosed her with Addison's, but she comes into the ER not from a boat accident, from a motor vehicle accident. And she had some trauma to her abdomen wall. What do you need to do immediately? Yes, give her cortisol. We're getting labs, we're giving fluid, all of these things, but why do we need to give her hydrocortisone? Because yeah, she has this acute trauma, right? We need to give her that, followed by infusions. We, of course, want labs, right, to confirm, but we just need to do that for sure. Okay, don't delay treatment for labs. IV fluids. Treat, obviously, why she's there. Well, that was meant for before day, for you guys to get outside. We can still do all the everything today. We can do it. All right. So, the patient has signs and symptoms consistent with hypercortisolism and is confirmed. That is confirmed on labs, right? So we know that already. We know the labs that we have to do. His plasma ACTH is low. Which one of the following is the most likely etiology of this patient's signs and symptoms? A, small cell lung cancer, ACTH producing adenoma, TB, adrenal adenoma or adrenal insufficiency.
Okay.
Here's some deltas. Yeah, yeah. Good job. Again, it's different in a case versus a question, right? In a question, maybe it's easier. I don't know, I like the case that's better, but here it is, just for studying purposes. If you didn't, you guessed D. And again, tuberculosis and adrenal insufficiency are low cortisol, right? And I don't test you on tuberculosis as a cause. It can be a cause for adrenal insufficiency primary, but we keep it with autoimmune. So we're at least down to 3, and then from there we use the ACTH tells us where the problem is, right? And this is why ACTH would be high in A and B, okay? Here's your slides that help you get there. All right, a 38-year-old woman presents with fatigue, anorexia, muscle aches, hyperpigmentation. Her labs are significant for low sodium and slightly elevated potassium. Which of the following is the most appropriate to obtain next in the workup of this patient? So do we do a cosinotropin stimulation test, do a MRI, a CT, 24-hour urine cortisol, or more cortisol? E, I hear E. Yeah, E. Labs before imaging. And we want to do E, because is this person presenting like Cushing's? No. I mean, fatigue, even if I didn't say if I didn't have the hyperpigmentation, the anorexia, muscle aches, but nothing stands out as Cushing's, right? So labs before scans. Now obviously I'm not doing a special test for this. We got it down to 2, and then we know that 24-hour urine is for excess cortisol. Here's more explanations if you need that. For studying. Okay. 47-year-old woman. This is an iPad question, right? This is less long. With a history of hypertension, presents to the ED with severe headache that began suddenly 3 hours prior to arrival. She has a history of recurrent frontal headaches for the last month and has recently been treated for migraine headaches. Today, she also complains of blurry vision, dizziness, weakness, diplopia, nausea, abdominal pain, and confusion. What do you think of her vitals? Hypotensive a little bit, a little tacky, respiration rate right at the edge at 40, no temperature, pulse ox 98, okay, phew, that's for Friday. Neurologic exam reveals bitemporal hemianopsia. What's that? Loss of what? Peripheral vision. She has mild hyponatremia. We give her some saline, and a CT scan reveals an intracellular mass. Which of the following is an appropriate step in the management of this patient? So, how does she present? Sick, right? Ish? Yeah, she's got some stuff going on. Yeah. Yeah, she's hypotensive. So we do talk about hypotension in endo. Talk about hyper a lot more, right? You see, use that. What is that neurologic? What does that tell me? Where do you think a problem is if somebody has the peripheral vision loss? And we know there's a mass there. Okay. Any guesses? Yeah. We think something's going on with the brain. We did some imaging and we saw a mass. And how do we treat this? We do saline, hydrocortisone, mannitol, or radiation. Anybody want to say a letter out loud so I can move on? I hear a C. Okay. C, mannitol. No. You could probably say some B. Okay. B. Okay. Okay. Here's stuff to help point you in the right direction. Sorry, I shouldn't teach you for volunteering. I'd rather you get it wrong because then we move faster. So we're down to these 2. When so saline fluids or cortisol. Why would I do B over A?
Yeah, because
there's something, I'm concerned with this adenoma. She's these headaches, migraine headaches, blurred vision. She's hypotensive, tacky. You probably do both. And it's the fluids. Oh, it's 3% there. Yeah, it is 3% hypertonic. So that's for SIADH. Yeah, you probably give saline, you give fluids, and then you do that.
Okay.
So if I'm going to give you an SIADH patient, what do I have to tell you? About their urine a little bit, right? I have to tell you their urine. They would be hyponatremic. I tell you more stuff. I want you. Okay. Yes, urine specific gravity, osmolality, all those fun things we learned. Okay, this one, I'm talking a lot. All right, 37-year-old male presents to your clinic for hypertension. He was on lisinopril 20, and we've increased it to 40. He's compliant with his meds, but over the past several visits, he has the following blood pressures. They all high yet. Physical exam's normal, and you get a CMP and potassium is low. What of the following would be the most important part in the workup of this hypertension? So you have to know the diagnosis. This is the third order question, and what lab do we do? 17 hydroxyprogesterone, ACTH, 21 hydroxylase ACTH, renin activity, and 24-hour urine aldosterone, morning cortisol, cortisone, 24-hour urine excitement. What are we thinking? A, I hear. Okay, what else? Keep going. C, I hear. I like it. And we'll talk about why it's not A in just a minute. So it's C.
Oh, yeah.
Okay. This is that other hormone that we talked about. We talked so much about cortisol, but don't forget about aldosterone, right? So this person has hypertension. They're not responding to meds. They're only 37 and they're hypokalemic. So, again, I've talked about cortisol a lot intentionally, but we've only talked about aldosterone once. So, the renin, remember the RAS? So, do we expect renin to be high or low? The PRA. If aldosterone's high, what do I expect the PRA to do?
Low.
Should be low, right? Yeah. Okay, so, and then we can do the 24-hour urine aldosterone for confirmation. So 17-hydroxyprogesterone is for congenital adrenal hyperplasia. So it's an androgen excess. 21-hydroxylase is the enzyme that's deficient in that case, right? So they're they have a ton of 17 but never get to 21. And then renin, again, it's because of the RAS. And then morning cortisol and cosinotropin is adrenal insufficiency versus E is Cushing's, okay? Problem solve that. All right. Okay, that's it for cortisol until next Friday. And the review. Okay. We are moving to the medulla. I like this one. It's not just because it's short, not to talk as long, but it's an interesting one. And we're going to kind of correlate the nervous system because we're going to talk about fight or flight, which is your sympathetic nervous system. So we know cortisol is released with stress, but then that fight or flight, we have other things that are released, right? What are our hormones that are released in fight or flight? Epinephrine, yeah. We're going to talk about epinephrine and norepinephrine here a lot. So here's our one condition, the pheo. We're going to talk about when you find incidental adenomas on imaging. We're going to talk about whatever this MEN syndrome is, and then end with hypertension, endocrine hypertension stuff. All right, so the medulla is the inside right here of the adrenals. Right, we talked all about the cortex before, and specific hormones are that it secretes. So the catecholamines are epinephrine and norepinephrine. Okay, and again, this is our fight or flight. This is another review slide. Okay, so what happens when I'm under stress? The endocrine cortisol kicks in, but right, we know that when cortisol or ACTH is released from the pituitary and goes to the gland, it takes a while, right? It's slower. So we need the nervous system to bump in, and we need it to go in fast. And so we get this stress stimulus, the hypothalamus gets a stress stimulus, and it goes down, the adrenal medulla is activated, and it releases our catecholamines, right? So what happens when we're in this fight or flight state? What happens to my heart rate? It goes up, right? I may need to run, right? So gluconeogenesis, I need some more glucose into the bloodstream to work. Is that glucose going to my muscles, or is it going to my GI tract?
Muscles.
Yeah, muscles, right? I don't eat poop right now. I need to run or fight, right? So all of this stuff is our increased metabolic rate, increased blood pressure, all of that stuff. This should be very much reviewed. This helps you with more details. This is what signals release of catecholamines. So, right, if my blood pressure goes to the hypoglycemia, especially in the night, will increase your catecholamines. So decrease in blood volume, blood glucose, and blood pressure. Severe illness, right? And then emotional stress. This all feels a review? Yeah? Okay. That's it for the review. Now I'm going to go straight to the disorder. It's the zebra that you hear about and hopefully don't see. I think, I might have this wrong, but I think someone was diagnosed with this, with a Theo or something, in IPAP at some point. I don't know. When you do your ultrasound stuff. Anyway, we'll talk about what this looks like. So, all right, so most of the time it's just the horse, right? But sometimes it is a zebra, and this is your zebra. Potentially will be on the pants. There's a few questions on my test related to Theos. It's a neuroendocrine tumor, and it's in the adrenals, and it just releases excess epinephrine and norepinephrine, right? Outside of this normal feedback loop. So I have an adenoma misbehaving and secreting excess epi and norepi, okay? Outside of our normal triggers. Periganglioma, do you guys know what that is? We talk about that. So that is, it's any kind of like release of norepinephrine outside of the adrenals. So it's usually, you'll see it in the upper extremity in the lymphatic system or up here, but I'm only testing you on the Theos, okay? Both are rare, and then they can, half of them are found incidentally, right? So on imaging, they have no significant symptoms, so we find them incidentally. But symptoms are important, right? Test you on this, I want you to be able to identify it. So you have your 4 key symptoms: hypertension, headache, diaphoresis, and palpitations, right? So this makes sense, right? Because when catecholamines are released, my heart rate goes up, blood pressure goes up, right? I'm fighting or flighting. But this is not due to a stress trigger, okay? So this, if you're feeling like this, these 4 things all the time or sporadically, that's a problem. A lot of these patients present with anxiety, though. I know it's like not the classic 4, but that sense of doom, the anxiety that it doesn't get better, that's the only time that Theo's been on my differential and primary care, and it's not very often, but anxiety, all the rest should make sense. Dyspnea, tremor, dizziness, weight loss, all of these things, these non-specific GI symptoms, again. All right, so what, do you think these people run around with hypertension, headaches, and diaphoresis and palpitations all day long? They probably come in to you. Most of the time, not always, most of the time it's episodic, right? Or you have the paroxysms. And those are triggered by exercise, changing positions, emotional stress. So IPAP, if you had a Theo, exercise, those stairs, bending over, do physical exams, emotional stress that you guys might have had. This would potentially pop up while you're here, okay? They last anywhere for 10 to 60 minutes, and they occur randomly, but there's your range. See, there's a table of drugs. I don't expect you to memorize these, but it is really important because you're going to be prescribing meds. So anytime you have someone struggling with these episodic symptoms, look at the meds, okay? But they make sense, right? Amphetamines, cocaine, caffeine, all stimulants, right? The interesting thing on here to me is obviously nicotine and decongestants, but IV contrast. So that's really important because if you give when do we give IV contrast? For a CT, right? So where is a pheochromocytoma located, right? It's a tumor. Where is it at? In the adrenals. So what imaging do I use to find it? CT. Do I want to give this person IV contrast? Probably not, right? Ideally not, because I could set them into an episode. And do I want to be in a CT scan and I feel like this? No. Does it happen? Yes, but know that you want to do a non-contrast CT when you're working this person out. And then general anesthesia can also trigger paroxysm of Theo. So you have these kind of like episodic stuff where someone comes in and is like struggling with these symptoms, and then you have the scary go to the ER situation, right? Hypertensive crisis. That's where that paroxysm is lasting longer. It's not getting better. Excess epi, excess norepi. This is not sustainable. And then you're going to have arrhythmias, hypertensive crisis. This is a very sick patient, and those are the triggers, right? IV contrast. We talked about glucagon. We'll talk about when you give that next block for diabetics. If you go and like do a biopsy of the mass, that obviously can make it angry and release excess catecholamines, and then surgery or delivery, right? Because what is a C-section or a vaginal delivery? It's stress, right? It's good stress, but it can, so obviously a pregnant woman who has an undiagnosed PO would be very scary. Okay. This is, I think, just like repetitive again. Hypertension is very common. Raynaud's, but they get really sweaty. Drenching sweats is not normal, right? Tachycardia, all of these things. The multi-system crisis is for situational awareness, right? That's that more like ER, the EMED class that you would have this. But again, if they present an extreme catastrophic, prolonged catecholamine release, these make sense. Okay. So we have a physical exam. We get a good history. What do we do now to work this up? Labs, right? What kind of labs should we do for this patient? If I'm in this high metabolic state, what have we talked about already that might be on your differential? We know we're talking about POs, but what causes tremor, tachycardia, thyroid, hyperthyroid, right? Or thyroiditis, right? For sure. So we should probably check that. So TSH and free T4. CBC all week. CMP are electrolytes off causing this. Are they hypoglycemic or hyper? So we need to do that, and then ESRs for inflammation. But we have specific tests it's not a suppression test or anything funky like my other ones. It's just plasma fractionated free metanephrines. It's the most sensitive test to diagnose this, okay? So of course you still need to do the labs up at the top, and you get why, especially the TSH and free T4. But we need to check metanephrines, okay? So if it's normal, whew, it's something else. Elevated, we need to go work this up further. Now you can also consider a confirmatory test, and that's a urine, 24-hour urine, specifically for metanephrines. Okay. And then genetic testing is super important, especially with the MEN conditions we have, but typically someone who has a PO might have some genetic abnormalities and need additional screening for other disorders, specifically like thyroid cancer or things like that. It'll all come together. This is like the come together lecture. This should be no surprise, right? Imaging is a non-contrast CT, right? Because we have this tumor in the adrenals that's producing excess catecholamines, norepi, and epi. So we're going to go there. Now, if it's negative, then I might want to look for other places, right? Maybe it's a paraganglioma, but am I testing on that?
No.
So it's going to just be a CT. Obviously, MRI is possible if they're pregnant or things like that. But again, I just needed an adrenal CT. I think if you do that, if you do an MRI and a CT together, it's 90% sensitive for a PO and adrenal tumors. But we keep it simple, just a CT. All right, so see the arrow, the mass? That's not supposed to be there. That's a bad tumor. These are pretty impressive when they remove them. Okay, so I've done my labs, my fractionated free metanephrines. I've ruled out thyroid conditions and other electrolyte issues. I did a CT and I have a tumor, adrenal tumor. I'm going to send them where? What do we need to do? We get this out, right? Because this is not sustainable. I don't want this person to have a hypertensive crisis and cardiomyopathy and all these things, right? So I'm sending them to surgery, endo, anesthesia, all these, anesthesia, a team needs to be there, right? Because we know that anesthesia can cause a flare. But my patient is hypertensive. or when they come see me, or they have these episodes of hypertension. So what you as PAs, what should your treatment be focused on while we're waiting for endo? Blood pressure, right? And there's a very, very specific medications you have to use, and unfortunately in a specific order to prevent a crisis. Did you guys learn this in ART? Maybe? Maybe it was, that was like 3 weeks ago, man, right? Like that, yeah. Okay, so we have to create an alpha blockade. We need to block the effects of epi and norepi on the blood vessels to prevent this unopposed alpha adrenergic stimulation, okay? So if for whatever reason that clicks hopefully for you, if it doesn't, then you could just remember AC before B, but ideally, look up alpha blockade and if you need more information on it, but we need to give an alpha blocker first, alone or in combination with the calcium channel blocker, okay? So doxycytin, nifedipine, we need to give those first. Then after that, we can give a beta blocker if they need it for like a tremor or their blood pressure is in control, okay? But we can't give these people beta blockers first because we don't want to send them into a hypertensive crisis and potentially die. Now, if I told you that 50% of these people, they're diagnosed with the FEO incidentally, right? They don't have symptoms. Are we still going to surgically remove that bad boy? Yeah, we are, because of how scary it can be, right? So, but if they don't have high blood pressure, we don't necessarily need to treat them. But there's, this is just like kind of like scary surgery. They still may, you wouldn't be the ones prescribing it, but the specialists may. And again, we need endo, anesthesia, obviously the surgeon in there. And then here is it's a 3 centimeter FEO. It's the right side, in case you were wondering. Yeah, no good. And then, so this should make sense. A lot of it's FYI, but like pre-op, we talked about that, right? Pre-op blood pressure control for at least the week before. But then during surgery, they're going to watch it really closely. Post-op, they're really going to watch it. And then they may add chemo for these patients because of the correlation with other cancers and things like that. So essentially, we're monitoring them before, during, and a long time after. A long time after, and that is because the malignancy rate for these things doesn't show up right away. So you're diagnosed with a FEO, they do the pathology, but they still need to watch for mets or metastasize because the metastasize from a FEO can show up years later. So again, lots of monitoring for these zeros if you ever run into them. Yeah, hypertension persists for 25%. And then obviously if it mets, they're not going to have as good prognosis. All right, you guys good to go through another, we're done with FEOs. We got 10 minutes before a break. I think we'll go through the multiple endocrine neoplasia or MENs, and then we'll take a break. So should be 10 or 15 minutes. Any questions on FEOs? Pretty straightforward. Very classic presentation, straightforward labs, and straightforward treatment. Okay, so there's going to be the PANTS has multiple endocrine neoplasia, or MEN, on its test. It's on the blueprint. Sorry you won't hopefully see this. So there will be one question on my test related to this, and there's 4 MENs. All you have to know is how to identify which one it is, okay? And I created a table last time, and so stay with me, and we'll go through the table, and then when we do the review, I'll go through it again, and I can teach you how my brain oversimplifies it if I were going to be asked a question for this, okay? All right, so these are essentially, like over time, really smart people notice trends. So if you have a personal and family history of certain endocrine disorders or adenomas, and they like classify them into these MENs. So again, family syndromes, multiple glands, so the pancreas, the pituitary, thyroid, adrenals, and if you have a handful of these, you're more predisposed. So if I have an adrenal tumor and a pituitary tumor, I'm more predisposed to have a certain thyroid cancer. Does that make sense? Or testicular cancer. Okay, so it's like correlation. They're germline mutations, again, family history and personal history. Okay. They're going to present differently depending on what tumor they have. Like, it's not like everybody presents with one and then the other, and then the other. It can be, this one's definitely like a puzzle to solve. The hereditary tumors with distinct patterns. This is a table from Current that breaks down, it compares the tumor type, parathyroid, theo, thyroid adenoma, breast cancer, with the different type. Okay, use that if you want. All right, MEN1 is the most common one. You don't need to memorize the time of life or when it happens. But again, signs and symptoms vary. It depends on, do they have a hyperparathyroid tumor? Are they having a theo? And things like that. So but the treatment for this is to remove any adenoma that's causing problems, okay? And this is how they present. 95% have hyperparathyroidism. So they have these parathyroid adenomas in their 4 parathyroid glands, and they cause excess calcium. So we do screening labs on patients who will have an elevated calcium. Hyperparathyroidism is what you're going to work up. Now, most of the people with hyperparathyroidism don't have MEN. But 95% of people with MEN have hyperparathyroidism. Facial angiofibromas, these are like small, I added a picture, like small, fleshy, skin-toned papules, and they're dome-shaped. Pancreatic tumors, pituitary adenomas. Do you guys know what a gastronoma, what that would possibly cause?
Gastritis?
Yeah, so it's like you'd have like PUDs, reflux, GI, like nausea, vomiting, like bloating, and then insuloma, you'd be like sweaty, shaky. We actually had an insuloma in eggplant at phase 2, which is kind of cool. And then adrenal adenomas. Stay with me, it'll all come together, I promise. All right, MEN2, a little bit different. So we have medullary thyroid cancer in the vast majority. We know that. That's one of the thyroid cancers I talked about. It's not very common, and they don't do very well, right? It's more aggressive. Theos, we talked about that. Often bilateral, okay, cool, and asymptomatic. So Theos, medullary thyroid cancer, hyperparathyroid, and Hirschsprung's disease. What is Hirschsprung's? Do you guys know that yet? It's a PEDS case, so maybe in GI. Yeah. So they'll have like bowel movement issues, and it's like in the large intestine issue. So these ones you're gonna find. Good job. Remember, these ones you're gonna find younger typically. Or if you have anyone who has Hirschsprung's, you're gonna screen them for all of this. The treatment is important on this. We need to remove the thyroid gland, especially if they have medullary thyroid cancer. But say this is a person who has a theo and hyperparathyroid and their thyroid is fine, they often remove the thyroid just based on risk, okay? And then probably the why we hear about this the most, the medullary thyroid cancer is GLP-1s. You can't give people who have medullary thyroid cancer GLP-1s. All right. Number 3, these people will have mucosal and GI neuromas. So they're like have these bumpy, enlarged lips and enlargement on their lips and tongues. Medullary thyroid cancer again. Okay, we're seeing that trend. Marfan-like habitus. What is that? What's Marfan? Oh, really? Yeah. They have cardiac stuff. Theos. Got that. Skeletal abnormalities, I would just tie that into the Marfan's. Potentially, there's other stuff too. And delayed puberty. And then again, we want to potentially prophylactically remove that thyroid to prevent medullary thyroid cancer that 80% of these people have. I'll tell you a trick I had for this one soon. And then, of course, 6 years ago, they made a 4th one. This one is very similar to MEN1 because it has the parathyroid adenomas, pancreatic, pituitary, and adrenal, but they also are prone to the stuff at the bottom, cancer, cervical or testicular, renal tumors. So I would have to share that with you to differentiate between MEN1 and MEN4. Okay. Here's that table again. Here's the table that I mentioned. So let's just talk about this for just real brief, and I'll talk about it more next week. So MEN1 and MEN4 are very similar, right? Parathyroid, pancreas, pituitary, adrenal. The biggest difference again is just for 4 they have to have some kind of cancer or tumor, okay? And then 1 is the most common. I don't care about treatment, I put it up there because it's for situational awareness. MEN2 and MEN3 are very similar because they both have medullary thyroid cancer. They both have PHEOs. And then when you look at 3, what do I see? I see mucosal neuroma, medullary thyroid cancer, and Marfan. So I see 3. 3 is like an M, 3 M's equals 3. I don't know, that's what I do. But there you go, if that helps you. There's your table. And then here's pictures too. All right, so we'll take a break and we'll come back at 11. So, adrenal incidentoloma, what does that mean? Break that word down. Incidentoloma. It's something that makes sense, right? It's an incidental finding, specifically of the adrenals, right? An adenoma found on the adrenals. Does this mean this is cancer? Well, odds are no, at least for the adrenals. But I will tell you, there's percentage of how many of these are adrenals, and it's pretty low. When you're in clinic, it feels like it's a lot. And typically what happens is someone goes to the ER, they get a CT scan, and then they come back with an adenoma that was incidentally found, and guess who deals with it? You guys, right? Or sometimes you are the orderer and maybe you have kidney stones or something, and you find like something on the kidney. Usually it's kidney and liver, at least in my experience, and what I find incidentally the most. And a lot of times you do nothing. But we're going to specifically talk about the adrenal incidentalomas. Okay, so found incidentally, only 4% of people who get CT scans have these, so it's pretty low. More common the older we get. So if I have someone who is in their 70s and have this, I'm a little more reassured than somebody in their 20s, right? That's a little more atypical, okay? So more common as we age. And here's the breakout of what they are. Vast majority are non-functioning, okay, 85%. And then you have 14% that are cortisol or aldosterone producing. We know what those are, right? Those adrenal adenomas that can cause Cushing syndrome or hyperaldosteronism, right? And then there's PHEO, METs. Obviously these percentages don't equal a perfect 100, there's a range. But anyway, what take home for this is PHEO is less likely as same as cancer. Okay. So I have a patient who I did a CT or someone else did, and they have incidental adenoma. What do we do? Yeah, lab. So most are non-functioning, so they probably feel just fine. They don't have the buffalo hump, the striae, or uncontrolled hypertension at a young age, right? Okay. So we're going to do an extensive lab workup, and if we're thinking Cushing syndrome, which we know about, hyperaldosterone, PHEOs, and then cancer, we're going to do labs that are related to the adrenals and pituitary, okay? That are correlated all to the adrenal glands. So these labs should make sense, okay? Plasma fraction-free metanephrines, what do those do? What are those working up? Is that a PHEO, right? What about plasma renin activity? Yeah, hyperaldosteronism, right? And that's right there with aldosterone. What about ACTH? Yeah, so we have an adenoma producing excess cortisol. Okay, so imaging, it's obviously it was already done. Yes, they're here. How do we treat these patients? The labs are going to be helpful, right? So if we have someone who has Cushing syndrome, so cortisol producing adenoma, what do we do? Yeah, surgery, right? Same with aldosterone, and then, but if it's non-functioning, we need to look at the size makes a difference, right? So if you have a smaller mass that is not suspicious, so there's nothing irregular about it, we can observe it. Of course, we still need to do those labs. We have to do those labs to make sure we don't have an underlying endo disorder. But a non-functioning in less than 4 centimeters, we're going to see them for serial CT scans. Not just the scans. I need to have them come in. I need to do a full physical exam. I need to do, like, ask them questions, right? I'm screening them for these different conditions. Then after that 12-month mark, you can do scans every 2 to 3 years, okay, to monitor sex. This is a non-functioning small, less than what? 4 centimeters. Now, if it's over 4 centimeters, you got to send them to surgery, okay? Even if it's non-functional. So I have a non-functional mass. I feel great, but my mass is 4.1 centimeters or something like that. Surgical consults, okay? And of course, if it's suspicious features, regardless of the size, I'm sending them for a surgical consult too, right? That makes sense? Questions on that? That's it. That's it for adrenal incidental. Very common sense stuff. All right, so this is going to kind of pull in, we talked about hypertension a lot, and throughout this, we talked about essential hypertension in Dr. DeBoer's class, and different causes for secondary hypertension. We're going to just hit home those endo causes, okay? Well, I have a patient who I'm evaluating for hypertension. What in their history, or physical exam, or family history, would trigger me to think secondary hypertension, another cause? Doesn't have to be endo, but what in their history would make me suspicious? I no longer think this is essential hypertension. I think it's
Cardiac history.
cardiac. What's that? Yeah, blood pressure meds are working. What else? What about age? Does that play a role?
Yeah.
Yeah, yeah. Family history, maybe, of like one of these MEN type stuff. So, hypokalemia without a diuretic. What is hypokalemia and hypertensive patient? Yeah, so what does that indicate? What endo disease? Hyperaldosteronism. Only in 37-ish% will they have hypokalemia, but again, that's one. Early age without a family history. This one I don't love, but it's from the book. A new presentation of hypertension in over 50-year-olds. It's like, I don't know. That one, to me, I guess, is part of the criteria. Isn't that the majority of people who have hypertension? Anyway, resistant to max dose of 3 medications. If I'm starting to max dose 2 medications, I'm starting to, it might be on my radar. Higher degree of severity, especially systolic. Well, I was well controlled and now I'm not. That's red flaggy. Paroxysmal. What does that indicate? If I have paroxysmal, episodic hypertension, headache, palpitations, sweating, yes, Sophia. Absence of obesity. You will have thin people with hypertension all the time, but I guess technically that's a risk factor. And then obviously signs and symptoms of an endocrine disorder. So more than just fatigue, right? I have to give you more. So out of all the things we've talked about this block, what are conditions that can present with hypertension? What did we talk about today? Pheo. All right, what else? Hyperaldosteronism. Yes. Cushing's syndrome or disease, right? What else? Hypothyroidism, yes. Technically hypo too, but more common in hyper. So like a thyroid dysfunction. What is there's an adenoma in the pituitary gland that presents with hypertension? It's not super common. Adam Sandler, that movie. What the guy in the Happy Gilmore have? Acromegaly. What was in excess? What hormone is in excess? Growth hormone, right? Yes, so that also. And then the ones at the bottom are more for next block. You guys know all this. You might not remember it. It's in there. I have faith in you. It's going to come back out. Okay, so again, I have this patient. I'm suspicious because of all these reasons that it's not just essential hypertension. These things are on my mind, as well as like coarctation and renal stenosis and all those glamorous cardiac kidney issues, right? But don't forget about endo. So if I'm thinking of this, I do a physical exam, a good history, what do? Always in endo, labs. All the labs. So this is kind of a summary of the labs that you know. Now, how do I treat these people? They all have like unique treatment things, but ultimately you're treating the underlying cause, right? So pull it all together with hypertension. That's it for new material. We have plenty of time to do the cases quickly. The more you participate, the faster I go. What do you have after me? Cardio. Okay. I'll probably. I never know how fast this one goes. I'll probably be done early, whatever you guys want to do with that. Okay. So and then again after this, I'll post all of the reviews. Adrenal medulla clinical correlation. So, Angelina Jolie. What does she look like? How does she look? Does she look okay? Sick? No. Yeah, stressed. She's stressed out. She had a headache. Let's find out. At least she's like conscious, right? You know that. I don't know anything other than that. Okay, 37-year-old female complains of recurrent episodes of palpitations, headache, excessive sweating for 5 months. Past medical history is nothing. Family history. She's adopted. Doesn't smoke or drink. What do we think of her vitals? Yeah, hypertensive, a little tacky, respiration rates 20, no temperature. She had a CBC, TSH, and CMP are all normal. Right? So that ruled out like a thyroid disorder. What's her problem? So what do we have to deal with as her PA? What do we have to tackle? Yeah, all the reasons she came in, right? Palpitations, headache, she's sweating. And then, oh gee whiz, she has high blood pressure. So, okay. So we do a physical exam next. Oh, no. Okay, sorry. Physical exam, we'll say it's unremarkable. Sorry. What do we do next? Labs. What labs do you want to do? We already had a CBC, CMP, TSH. Let's say she's not pregnant either. Yes, metanephrine. Right? And they are elevated. What can we also consider to confirm this? A urine, 24-hour urine, and it is also high. So, based on what you're thinking, what do we do? I have my labs. Do I need more labs, or can I go to rads? Yeah. What do I want to look at? CT. Contrast or no contrast?
No contrast.
Yeah. We're thinking of likely a Theo, if we know what kind of imaging. Oh, there it is. A 3-centimeter right adrenal mass. Okay. So, do we have our diagnosis? Yeah. How do we treat this?
Cut it out. Surgery.
Yeah, surgery. We're kicking her to all the specialists. Everybody's going to want to be in that OR to monitor this patient. But she's hypertensive, right? So what does my treatment entail? What is key to prevent what kind of crisis? Yes, hypertensive crisis from the alpha blockade, right? So what med do we use?
Alpha blockers.
Yeah, or calcium. What are those meds? Yes, me. And then obviously your alls for your beta blockers. So what can maybe indicate for further workup? Oh, the MENs that you're just going to memorize right. Yeah, so the 2 and 3. Yeah, perfect. Okay, questions? Yeah, it's pretty fun. Easy, I think. Cerebellum is here she is. This is endo, I know, but we got some fun stuff to look at. Any thoughts? Yeah, maybe she's got a pretty big shiner, a laceration. This is fun when they come in as a student, because that means I get to clean that up, potentially suture her. All right, so she's a 64-year-old female, involved in an MBA and brought to the emergency department. She has a history of high blood pressure, takes hydrochlorothiazide. Family history is nothing exciting, and same with social. Blood pressure is fine, physical exam is fine, obviously except for laceration and stuff. They do labs and imaging because of the MBA. Something led to a CT, and we have a 4.5 centimeter right adrenal mass. They discharge her, they treat her stuff, and now she comes to you guys. What do we do? What is this called? Adrenal incidentalomas. What do we have to do? We already have the imaging done. Yes, but before the surgery consult or with the surgery consult, what can I do? Labs. What do my labs focus on?
All of it.
Adrenal stuff, right? Not thyroid. We don't care about that. It's like the adrenal stuff, right? So all of the adrenal and the pituitary stuff. Okay. Now her labs are normal. So it's a non-functioning 4.5 centimeter. Now, like you said, surgery, right? Yeah. Okay. Based on size, even though it's non-functioning and nothing about it is irregular. If it were smaller, we know the difference of how you treat it if it's smaller. Oops. Oh, where's his picture? Oh no. Okay, we have neonatal. Curious. What do you guys think of him? Anything?
Looks
No
normal.
trauma, no. Looks alert. He's not in pain. Maybe a little chubby. I don't know. He's fine. No, he's fine. He's fine. I don't know. It's just because he's smiling. Maybe he has chew in his mouth or something. Anyway, 28-year-old male needs, or he comes in, needs routine, or he's here for a routine follow-up for high blood pressure. He feels fine, except for he's having headaches. He's had high blood pressure for 2 years. Doesn't smoke or drink. He's on lisinopril 40, atenolol 25, and his dad has high blood pressure. Anything stand out now? 28-year-old male. He's had high blood pressure since he's 26. Oh, but my dad had high blood pressure too, so. He's on how many meds? 2 meds. Okay. What are we thinking? Any endo-y things yet? Yeah. We need to probably do a good physical exam. Sure enough, elevated blood pressure, upper extremity. His records are the same. He was controlled in the past, though, apparently. Maybe when he was 27. We do an eye exam because you guys are good PAs and we love the fundoscopic exam and all the beautiful things we see on that. Of course, heart, lungs, abdomen, everything is normal. What do we do? Labs. What labs? So which labs? So hypertension labs, what do I do? CMP, CBC, LUA, yeah. TSH maybe because we're in endo. That could cause hyperthyroid. Do you think this guy is Cushing's?
No.
No, right? Yeah, no. Do we think he has a VO?
No.
No, not yet. Okay. So we do our routine labs. Phew, it's not a thyroid disorder, but his potassium's a little off. What are you thinking? What hyperaldosteronism? What's the cause of hyperaldosteronism? Primary hyperaldosteronism is an adenoma or bilateral hyperplasia of the adrenals. So an adenoma spitting out excess aldosterone, or hyperplasia, increased activity, aldosterone goes up. Okay. So what labs do we do? Yeah, aldosterone, and what dictates aldosterone release? Renin. So ACTH, but what dictates it more than ACTH? Renin, right? That RAS. So let's do. Oh, sorry. Problem list. You guys got that? Here we go. PRA. Why is the PRA low? Because it's doing what it's supposed to be doing. The problem is that is something in the adrenals, right? Where's the problem? It's a primary problem. So we do a CT, and we know they have hyperaldosteronism. We do a CT. We send them to internal medicine and endo. We can consider that 24-hour urine aldosterone. And again, unregulated aldosterone secretion from the adrenals. Could be hyperplasia or an adenoma. All right, I have a few of these, and then that's it. What is the classic symptoms for a VO? These are the 4 options. I hear Bravo. Now, see, they can have anxiety, but not so much cough. Diaphoresis, so there's a little overlap, but you guys were paying attention. Look at that. There you go. All right, a 32-year-old female presents with a personal and family history of medullary thyroid carcinoma. On exam, she has mucosal neuromas. Oh wait, no, that's not the one I want. Hold on. The wrong one. Here we go. This is the one. Okay. Okay. Restart. A 32-year-old male diagnosed with renal tumors. A thorough medical history reveals a personal history of testicular cancer and parathyroid adenoma, as well as a family history of pancreatic neuroendocrine tumor and a pituitary adenoma. Ooh, this is a bummer. Which of the following neoplastic syndromes is most likely?
help out the.
Yeah, because of why, the renal tumors, the
Particular
cancer, yeah.
cases.
And then the parathyroid pituitary pancreas, the 3 Ps with some cancer. Good job. That's it. This is all the stuff we talked about in one block. Over secretion versus under secretion. Again, we'll have the review and the lab. The lab is very much participation and it's harder than the test. So if it clicks for the lab, you should be good on the test. I know you won't believe me. So, the test is still hard because it's endo. But yes, good luck on home. I'll post these and I'll see you guys.